welcome to this episode of the Mama Podcast. Today we are joined by Dr. Sarah Silberstein, and we are going to be talking all about breastfeeding. We've got lots of tips for you, and talking about tongue tie as well, because you're also a specialist with tongue tie. So please, Sharon, introduce yourself. Tell us all about you. Tell us about your expertise, where you work, and your family life situation, because we'd love to know who you are and what you do.
Okay, so my name is Dr. Sarah Silberstein. I'm a medical doctor by training, and I started specializing in lactation and breastfeeding 12, 13 years ago. And I have seen thousands and thousands of families since, mainly specializing in tongue tie divisions and diagnostic, but also, all of the tongue tied babies that come will always have a feeding assessment. Many of them are breastfed, so I will always help with the lactation side of things. I also do something which is a very small niche, but also is kind of not many other doctors do this, which is induced lactation. So I help a lot of parents via surrogacy, so mums who become parents via surrogacy, to breastfeed, also adoptive parents, same-sex couples who want to share breastfeeding. That's kind of one of the niche subjects that I love. Absolutely love working with this kind of niche group of parents. Always gets me very excited when mums can fulfill their dream to breastfeed, where they have been on a very long journey to get there a lot of the time. So that's really, really lovely. But yeah, a lot of the work I do is around tongue tie. And I am the owner of the Dr. Silberstein Clinic in Northwest London. I opened the clinic 3 years ago, and before that, I was kind of more on a rental room basis and working in North London, and also some of the time in Harley Street. But I consolidated all of it just into my own space. And now there are also other people who work at my clinic. I've got an osteopath, a speech and language therapist, and a couple of other lactation consultants who work with me. We run groups, we run pediatric first aid courses and breastfeeding groups. And so there's a lot happening at the clinic, baby massage. So the idea was to have kind of like a multidisciplinary team, and kind of getting people the help they need from kind of, from the beginning to the end, kind of, so that they would be able to access various services in one place. I'm also a mother of four. I have a 16-year-old, 15-year-old, 12-year-old, and 8-year-old, 3 boys and a girl. Also have 2 dogs and a house. My life is super busy and very full, and I work full time. Most days I'm at the clinic. I see 7 or 8 families in a day. And yeah, and I absolutely love what I do. I think I have the best job in the world, and work never feels like a burden. I always feel happy to go in, and I feel good when I come home, that the majority of the time I feel I'm able to make a difference to the families, and I can make the very, very difficult journey they may have had with feeding a little bit easier. And that is super satisfying and very nice to know.
Gosh, wow, your clinic sounds amazing. How fulfilling. You've got so many different strings to your bow. You obviously offer so much different support. That's absolutely fantastic. So how do you help the same-sex couples with the breastfeeding? Because that's absolutely wonderful. That must be really rewarding when they both get to experience that.
Yeah, exactly. So so the pregnant mother is often wants to breastfeed, but also share it with the mum who wants to induce lactation. So I help them with a protocol where there is 2 different medications involved. So they take the medication, and then I take them through a pumping protocol for about 6 weeks. And then they usually then share the breastfeeding together.
That's so lovely. That's absolutely fantastic. So you said you really specialize in tongue tie, and you see a lot of families that have tongue tie. So can you explain to us, exactly what that is and how would you know if your baby has got tongue tie? Is one of the symptoms the fact that you're finding it hard to feed the baby?
Yeah, so the definition of a tongue tie is where the little frenulum under the tongue, that's a little piece of skin that majority of people have. When this, so having that string under the tongue isn't as such a pathology. It's normal to have a frenulum under your tongue. So when you lift your tongue, you will likely see something there. But the definition of a tongue tie is when this little string is too short or too tight and often thick, and that will limit the normal tongue movement and also the function of the tongue. So that means that the baby isn't able to move the tongue out or up or side to side, sometimes all of it. So we talk about majority of parents will have come across the anterior ties and the posterior ties. It's not such an important, it's not so important to define it, but all it means is the anterior ties is when that frenulum is attached to the very tip of the tongue. Those are the most obvious and the most easiest to diagnose, because when the baby cries, you can see it right to the tip, it's right there. And the posterior ties is where that frenulum attaches further underneath the tongue. Those are less obvious. That doesn't mean they are less impactful. Sometimes a posterior tongue tie that attaches to the back of the tongue can impact feeding as much as it would be with an anterior tie. I've seen very severe looking anterior ties with very limited tongue movement where the baby actually can feed okay, and tongue ties which are posterior where the baby is barely able to feed. So just by looking at it, you can't assume anything, so looking at a tongue tie always has to come with a proper assessment of the just the visual aspect, what does the tongue look like, but also a functional assessment of the tongue. What can the tongue do? And it will always come together with a feeding assessment. What can the baby actually achieve with their tongue movements? So looking at bottle or breastfeeding. The NHS has some clinics, and depending on their criteria, they will see sometimes only breastfed babies. They will sometimes only see babies under a certain age, sometimes 6 weeks, sometimes 12 weeks. And they have sometimes very specific criteria, and they will often not see babies, for example, that gain weight well. So they will completely dismiss that the mum is in complete terrible pain and has nipple injuries, but they will say, okay, the baby is doing fine, they're gaining weight, so we don't need to resolve the tongue tie. So in the private sector, it's different. I see babies that are bottle fed because bottle fed babies can also struggle with feeding. So their bottle feeding can be very disrupted. They can often, even if when you choose a slow flow bottle and a specific hold, so what we call this paced bottle feeding, even if you implement really good strategies to feed this baby, they often cough, they splutter. You can often hear a kind of clicking noise, so they go. That's a very it's almost a telltale sign of tongue tie. So most babies that click loudly have a tongue tie. Some don't. Some have what we call a high arched palate, where the roof of the mouth is shaped like a bubble or like a dome. So those can also click, but the majority of babies that click loudly will likely have a tongue tie. They often dribble, they cough, they choke, they often gulp a lot of air. So a lot of babies with tongue ties that are bottle fed might have symptoms of reflux. So they vomit a lot. And what often happens is these babies come to me after seeing a pediatrician, often like an allergy specialist, because they vomit so much. They are actually misdiagnosed with a cow milk protein allergy, and they often are on specialist formula. They've been prescribed medication for reflux, but really, when you look at how they're feeding, it's a mechanical issue of swallowing air. So the air goes down and it collects in a big bubble in their tummy and pushes up the stomach contents. So these babies vomit a lot. And they are often very unsettled. They're unhappy babies. They don't sleep well. They need to be held upright for hours in the day. They can't be put down. They're grunting. And they're burping loads, and with the burp comes the milk, and they are difficult to feed. So they, take small volumes. So they're feeding all the time. So these babies are very difficult to feed. So bottle fed babies are absolutely, need to be treated for tongue tie if it's there, so, and then the breastfed babies on there, so the symptoms can be the same for the baby. Also, they can be leaking on the breast. So when they're feeding, it can be like very messy, very disrupted, coughing, spluttering. We often see that. Windy babies, also reflux, and then disrupted sleep because of that. And they sometimes don't gain weight very well because their feeding is often it's a high effort for them, so they fall asleep a lot when they're feeding, so they get very fatigued, so they often don't finish feeds, so their weight gain can be impacted. And on the mum side, we often get severe nipple injuries, pain, ongoing pain. They often have recurrent mastitis because the babies don't drain the breast well, so they are left with a lot of milk behind. So baby doesn't remove it, mom's left with a lot of milk in their breast, and they get mastitis because of that recurrent blocked ducts. And then and often also vasospasm, which is a condition where the nipple turns white. It's very painful. It's stabbing pains through the tissue of the breast as well. So, the symptoms are on both the mom's and the baby's side a lot of the time. But, you can get kind of almost like a mixture of all of these symptoms, and it requires a specialist to kind of pick out what's what and to see the holistic picture. That's why we can't only look at a picture and say, oh yeah, this is tongue tie. We always need to see the full situation and see the baby in action. So when people send me a picture, can you tell me, is this tongue tie? I can see, I can tell them I can see a frenulum and it's likely, but I need to see everything. And then I will give them a full assessment, take them through what I can see. And if I recommend it, we may do that procedure during the same appointment. And then I will give them often a feeding plan because, when the baby comes along and hasn't been gaining weight well, I will then advise them on what to do. For example, if they need to start pumping and topping up, how to do that, what quantities, we check the baby's weight, and I will often bring them back for a follow-up depending on what I've advised. And or sometimes there is low milk supply, we work on that, or there is mastitis, we work on that. So there's lots of kind of it's I always say that it's never just the tongue tie. It comes with a whole host of a rat tail of issues to address usually.
That is so helpful. That is really, really helpful. I remember when I had my babies a long time now, and I really struggled with breastfeeding. I really struggled with the pain. At first I was told, that it was reflux because my baby was being sick a lot. So they recommended the Infocol, and I remember having to squirt that into the bottles as I was making the bottles up before every feed, or giving it to them before I was trying to breastfeed. And it was really, really difficult. And my daughter, in the end, was diagnosed with tongue tie. And so we did get that checked. But obviously, this is going back 11 years ago. She's 11 now. And I don't remember being given like a full assessment, like them asking me all these questions and everything. So this is really helpful. This is really interesting. And I also remember 11 years ago trying to find someone that could do tongue tie. Like the waiting lists were so long. And as you've just said, there's a criteria that some clinics want you to fulfill. So what if baby is over 6 weeks or 12 weeks? Where can we go to support? Where can we go to find out whether our baby has got tongue tie, and whether that needs addressing?
So the um unfortunately, the training in the NHS, the midwives are not reliably trained at diagnosing tongue tie, and daily I see babies who have been diagnosed with tongue tie where in fact it's not, and vice versa, where they have, told the parents, oh, it's mild, and then it's like really severe or something like that. So it's not reliable, unfortunately. And unfortunately, this whole tongue tie situation in the UK is still quite poor, and the lists are far too long. So if you have a newborn with a tongue tie that doesn't latch, it's pretty much the only option to really go private, because even 2 weeks can be far too long if you have a baby that just can't latch, and sometimes by the time you get to the 2 weeks, the breastfeeding is kind of gone, right? So I think the best bet is to go to the website for the Association for Tongue Tie Practitioners, the ATP. And the ATP it has a register of everyone who is a tongue tie practitioner in the UK, and you can search by postcode. There aren't any, reviews on there. They're not kind of vetted as such, but the vast majority of tongue tie practitioners have their own websites. So you can kind of go on there, you'll see everyone's details, and the majority, so everyone who's listed on the Association for Tongue Tie Practitioners is a healthcare professional. Majority will be midwives and nurses. I personally prefer it when the tongue tie practitioners are also IBCLCs, so International Board Certified Lactation Consultants, because a tongue tie isn't just a tongue tie and it comes with all of the feeding issues. I think that it's helpful when the the person who addresses the tongue tie can also address the feeding challenges. So I think it's, and a lot of them are, so if you have the choice and there is a tongue tie practitioner listed who's a midwife, it would be helpful if they were also an IBCLC at the same time, because then you don't need this and that. You can just kind of consolidate it into that one person who can help you with all of it.
That's really helpful. That's a great place to go to. Thank you for that. Um, I was just thinking for me, well, because I said I really struggled, and part of why I struggled was because my daughter had tongue tie. But what can you do when the pain is just so much? What is it that we need to do and be trying to help ourselves with when it's so painful to breastfeed? Because I assume it's not normal.
Yeah, so that's actually true. So, some moms are told you, oh, just suck it up, buttercup, like just to bite down on it and it'll be fine, it's normal to suffer a little bit. That's not true. Pain is never normal. So the one thing I always tell the people is it's to look up something called the exaggerated latch or flipple technique. So flip the nipple. It's something you can look up online. There's lots and lots of helpful videos on YouTube, but the flipple technique makes the biggest difference. I think that a lot of babies, specifically tongue-tied babies, need a lot of guidance towards the breast. They have often, because of the restriction in tongue movement, they often have not got the ability to open really wide. So their gape is often small because of the restriction under the tongue. So those babies, you need to basically do a very kind of guided latch. I think it often works better. The other thing to look at potentially is the laid back hold, which is a position where the baby is kind of straddling the mum's leg and kind of prone onto mum's body and coming from underneath the breast up. So it's kind of a very relaxed position. That's a little bit kind of tricky to learn maybe in the first couple of days, but I think with a little bit of guidance, that can be a very nice position for any mum, but also for mums with tongue tie, because because baby's head is almost like on top of mum's breast. Gravity can help with the wide latch and is often less painful. So So between those two positions, those are kind of my go-to. So the flipple technique and the laid back, so they work really well. Side lying is also really helpful because when babies feed frequently and it's painful, side lying can also help. So when you're in bed and your baby is next to you on the mattress, that can help. But if the pain is so impossible and you have to wait for the appointment, sometimes nipple shields can help when they are used correctly with some guidance. They can be absolutely life-saving, and they can often tie you over to that point where you can get professional help. There are some good YouTube videos, again, how to put a nipple shield on. There is a technique. So you can't just kind of put it on like a hat. There is a
Yeah.
little kind of
Okay.
eversion technique and a little stretch where you put that shield on properly
Okay. I could have
and
done with
making
that tip.
sure and making sure that your baby still latches properly and deeply so that they don't suck in the tip, because that can still be painful. The other thing is if everything else fails. So, sometimes when I have a mom that comes to me, their nipples destroyed, right? So, where there's several layers of skin missing and it's just a bleeding mess, right? Sometimes I have to say this, the mums are like often so in it, they're like they can't see
Mm,
beyond, they're
mm,
so, and they want to make this work so desperately that I sometimes have to be the one, we just need to like call it here. You can't carry on like this.
mm.
Look at your nipples, they're missing skin, like the bits falling off. Where I have to say, okay, we need to just stop what we're doing. We have to start a pumping regime. We have to give your nipples time to recover. I often offer something we call low level laser therapy, which is it's a as the name says, a low level laser, which can help the skin cell turnover. It can help the nipples to heal quicker. That can help to reduce the pain levels, and it can help to recover. So I do often do laser in my clinic, and I use the particular dressings. They're called Gelonet. They're used for burn wounds, and Gelonet is super, super helpful for those open injuries where, nothing can touch it. Some mums like to use silver shields as well. Silver shields can be used for 20-30 minutes after feeds. I would not use them round the clock. Silver shields are amazing, but they're not so good if we leave the breast milk to soak for 24 hours, because that can be, that can make the skin very soggy and can hold the healing process. So yeah, so the laser therapy is not something that many people offer, but I'm hoping that more lactation consultants will pick up on it, because it is really good. And yeah, the Gelonet, I tell everyone, you can get that on Amazon or in pharmacies. It's a burn wound dressing. It's readily available, and it works so, so well. It's just a breathable gauze that's dipped in Vaseline, so it's very pure. Um, and it works so well for these deep injuries. So yeah, sometimes we just have to call it for a week and just do exclusive pumping and bottle feeding, because sometimes it's gotten to that point where
Mm.
you're this injured, you can't carry on.
I'm so pleased you've said that because as mums, we do tend to want to be super mum, and we don't always know when sort of when we need a break, you know?
Yeah.
And to get to the point where we've gone to a specialist such as yourselves, it's obviously got to a certain stage where we recognize actually we need some help here.
This is actually a good point you're making. I would, in my ideal world, every single mum would have access to a lactation consultant before you need to get to a
Yes.
point where your injuries are so bad that you have to stop feeding. It
Yeah.
would be so amazing, and the breastfeeding rates in the UK would skyrocket if mums like you had help early on. I think everyone should see a lactation consultant even before they give birth, to go through. colostrum harvesting, how to collect colostrum, how to hand express. So hand expressing, for example, can really make a huge difference in those early, 24, 48 hours when your baby cluster feeds round the clock and you're getting sore and sore. Every feed is, and they're on you for like 4 hours. To know the technique of hand expressing can be make or break. It's amazing. And also to go through what's normal, what's not normal, what are the red flags, what do I need to look out for, when should I seek more help. So I think antenatal consultations, most IBCLCs offer them, and they can make such a big difference because you go for birthing classes, right? Majority goes to antenatal
Yeah.
class, and we put so much effort and time into prepping our birth. In the end, we can't influence what's going to happen anyway, right? But we've got these birth plans, pages long, and I want this, I want that. In the end, you'll have a C-section, right? As it happens, you know. But with breastfeeding, it's like, you've prepped everything minutely up to the point, and then all of a sudden there's like a baby there that needs to feed, and you've got no clue what you're doing, right? And it's a huge steep learning curve. There's so many variables. You don't know, this baby screaming and they're hungry. Where is the colostrum there? I don't know where to go, what to do, how am I even going to latch this baby, and there's so many. And often midwives are very busy on their postnatal wards. They can't always, and sometimes it's very much like they come in 2 seconds, yeah, latch looks good, goodbye, and you're sitting with a screaming baby, and it's painful as hell, and your toes are curling,
Yeah.
and then you're off home, right?
Yeah. And I
So
bet you wish that people had come in to see you a lot sooner than
yeah.
what they had. And for me, I really struggled to breastfeed my son. It was really, really hard. So then when I had my daughter, I was even more determined that I was going to make it work with her. And like I said, I pushed myself through that pain barrier. And even talking about it now makes me feel ill because it was so painful. And again, my toes would curl. I'd have to take a really deep breath because I knew how painful it was going to be. And then I suddenly thought, oh my goodness, we've finally got this tongue tie appointment. Everything's going to be great. But of course, there wasn't any after support again. It was really, really difficult. And then I got mastitis, which again was horrific. And I just remember someone saying to me, "Oh, she needs a cabbage. She needs to go and get a cabbage." So my husband went out to get this cabbage, and I thought, what do I do with cabbage? So I'm really glad that you mentioned mastitis earlier, because again, I think we need to sort of raise awareness of the symptoms. I mean, my symptoms, I just describe it as knives being dragged across my chest, basically. Um, it was horrendous. But what can we do for mastitis?
So the majority of cases of mastitis is actually caused by insufficient milk removal. So when milk sits in the breast for a long time without being removed, that can cause an inflammation. Initially, you may feel it as a lump, um, which we would initially just call a blockage, which is actually not. Yeah. So a blockage is basically a localized inflammation where, um, there is a little bit of tissue swelling, and the tissue swelling narrows down the ducts, which then, you can feel as a blockage. It's not an actual plug that sits in your ducts. It's an actual local swelling, local inflammation. And that left untreated often turns into a mastitis. So mastitis means that you have basically a local inflammation plus generalized symptoms like fever, rigor, feeling unwell, flu-like symptoms, feeling weak. So that's kind of mastitis. If you just have a painful area in your breast, it might be a little bit red too, without any of the general symptoms, without fever, that would be just a blockage. The guidelines are new around mastitis. They've been changed about 3 years ago. And the guidelines are not anymore that we throw antibiotics immediately at the first blockage. it's not recommended. Having antibiotics needs to be considered carefully, because obviously the baby will also get a load of the antibiotics from the mum, which can also wipe the newborns or the baby's gut system. They can develop thrush, they can be unsettled, their tummy might suffer as well. So antibiotics would only be needed if the mum has a fever over 38.2 degrees, and if there are symptoms that don't resolve with conservative treatment. So the cabbage you mentioned is not just an old wives' tale. It does work. Mustard oil is the stuff in the cabbage leaves that actually helps to reduce swelling. Been historically used for centuries, and it is actually helpful. I use cabbage leaves as well for patients with blockages and mastitis, and it can be a nice kind of way to resolve the swelling. Sometimes it's not enough, so we usually treat mastitis with ice. So ice round the clock, ice blocks, ice, peas, whatever you have in the freezer.
Or
Don't use
frozen
heat.
cabbage leaves.
Yeah, or frozen cabbage leaves, but don't use heat. Whatever you do, any inflammation in your body, like for example, let's say you sprained your ankle and it's red and hot and swollen, the first thing you wouldn't put on is heat, right? It's the same with a breast. I don't know where this comes from. People are told put heat on, take a nice hot shower, and then massage, right? So that's not what we want, actually, quite the opposite. So ice round the clock, ibuprofen. Some people, they can't take it, but most people can take ibuprofen to help with pain. And again, it's anti-inflammatory, so ibuprofen is helpful. And then you could take that round the clock. You can take 400 milligrams 3 times a day. And then the massage. So when we say massage, we're talking about lymphatic drainage massage. So lymphatic drainage is different to a deep tissue massage. So some mums think, oh, there's a blockage, there's something plugging my duct, and then I need to go in with my fingers and rub and kind of push it out. That's really not
Yes.
what we want. If you imagine you have a tissue swelling, there's extra tissue water, and that's narrowing down the ducts, and it's making it difficult for the milk to flow. Rubbing it and causing extra swelling there is not going to help. So we want to actually treat the breast very gently. And lymphatic drainage, we use just our flat hands and with sweeping motions from the areola upwards on kind of into the clavicle region, upwards into the armpit, into the midsection between the breasts, and kind of underneath as well. And we can also use very gentle kind of circular motions, and we can use very gentle with our knuckles, but just everything should be the pressure like stroking a cat. Everything is gentle to the breast. So we don't want any kind of, crazy deep tissue sports massage to the breast, because it can exacerbate the inflammation that's already there. So those are the kind of conservative treatments. In addition, there is some evidence for taking probiotics, high dose vitamin C, 2 to 3,000 milligrams. So like you would during a flu, Also, what some people are told, that's a myth, that you have to keep that breast empty, so they go and express loads and loads. That's not what we want. We want to continue feeding as normal. Sometimes during the mastitis, the flow can be reduced because of the extra water inside the breast, because it narrows the ducts down. The flow can be reduced. So making sure that that swelling goes down is a very important factor in reducing the inflammation. So the main aim of what we're trying to do is to just reduce that pressure in the breast. One thing that I also offer in my clinic, again, there's not that many people who offer it, but is therapeutic ultrasound. So therapeutic ultrasound helps with reducing the swelling and reducing the inflammation. And it's such an amazing therapy. It can really halt the progression into mastitis if we use it early. It's an amazing a thing I've been using for the last 2 years or so. It made such a difference to some of my patients. Um, yeah, so basically trying to halt the progression into that stage of mastitis. Sometimes it can come in very quickly where you don't even notice the
Mm,
first stages. I've seen this before where some women say within hours, or they woke up the next morning very ill.
mm.
That can happen. So if you are extremely ill, your temperature is, let's say, 40 degrees, you're shivering, you're sweating, that would be the point where most definitely seek your GP, and you may well need a prescription. But it's important to make sure that you get the right type of antibiotics. The gold standard is flucloxacillin. That's the kind of common standard one, unless you're allergic to penicillin, in which case something else might be prescribed. And then the guidelines say 10 days as a minimum. So giving a 5-day course is not helpful because we know that the recurrence rate is higher if you're giving a short course. So that's something that a lot of doctors don't know, but also obviously the patients don't. So 10 days is a minimum for mastitis.
And getting help sooner rather than later, rather than trying to push through the pain like we mentioned earlier. And
Always.
I was just thinking what we were talking about earlier. What would be your top tips, your recommendations for women? So they've gone through their birth plan, like you were saying, and what can they prepare feeding wise for when they do give birth and they are handed their baby?
So definitely consider collecting colostrum before birth from 37 weeks onwards. Even so, there is some people who say, what if I give birth early because nipple stimulation causes some uterus contractions? It is highly unlikely that colostrum collection starts labor. It really isn't. So it is safe for the vast majority of all people. So familiarize yourself with the technique of hand expressing, start colostrum collection at around 36 weeks. That would be super helpful if people would be able to do that. And they can
Do you
come to
store that
hospital.
in the
Yeah,
freezer?
yeah. So the 1 milliliter sterile syringes, you can buy them off Amazon or in pharmacy. Sterile syringes, they're single packed. So you put them make sure you label them with your name and your date and the date you collected it. And then you can put them in a clean Ziploc bag in the freezer. And then if you go into hospital, someone else can bring them, or you can already go in with them. They last in the fridge. Um, and then you may or may not need them, but I think there isn't a situation in which a newborn that gets an extra 2 milliliters of colostrum will not feed because of that. Like that will always
No.
come in handy.
I'm just thinking my daughter, I went in to be induced, ended up having an emergency C-section, and then she had to go to NICU, and I couldn't join her for, gosh, a good few days. I had nerve damage. We won't go into that, but I was bedbound
Gosh.
basically, and I couldn't get up to the NICU. So I had to hand express the colostrum with the syringe. It was really, really hard. So I'm just thinking in those sort of situations as well, that would be perfect. Dad could take in the colostrum that's in the freezer and give it to baby. Yeah, that'd be a great situation to be in.
So definitely that's one definite top tip. So the other things are, like I said, with the flipple technique, that's something everyone should know about because that can make a huge difference. The flipple technique is something to look up. Um, and then also the laid back hold. Some people call this biological nurturing. That's a beautiful position to learn at some point. Doesn't have to be from the fast feed, but some moms are able to do this beautiful breast crawl where the baby gets placed on the chest and the baby's kind of making their way to the breast. Um, from the beginning onwards, I would always say monitor. That's one thing, to monitor nappies, nappy output. That's like one thing that is another myth that goes around online, where mums are told, oh, breastfed babies don't poo that much because they're utilizing all of it because it's all nutrients. That's nonsense, because breastfed babies do stool and they have an output. If they are breastfed well, we usually look for about one nappy, two nappies in the first 24 hours. It's usually meconium. That meconium starts turning from black to green to brown to yellow. So that transition of colors should have been completed around day 5. If by day 8 the baby still has brown stool, there is something not right. And usually in that case, it's reflected in poor weight gain. When the babies don't have enough intake, that transition is slower. So that tells me something. I want to know that they're stooling the correct amount and the correct color on each day. So that's something to read up on for the mums out there. It would be good to know that each day that this color changes and the quantity increases from day to day. So day 2, around, it's a good rule of thumb. Day 2, 2 nappies. Day 3, 3 nappies. Day 4, 4. Around that. And the same for wet. But if a baby doesn't poo, that's something to troubleshoot. I have seen occasionally babies who have stooled less than that, who've gained weight well and who fed well. But the majority of babies who have reduced nappy output, there is something up and it's something to investigate. At least speak to an IBCLC. If your baby hasn't pooed for 24 hours, troubleshoot for sure. And the other thing with the wet nappies, if you see urate crystals, looks a bit like blood. It's not blood. It's a little bit of an orange stain in your baby's nappy. That can be a sign for dehydration. So when we see the little urate crystals, or the little brick dust, some people call it, that is again something to look further what is happening, because that can be early signs for dehydration. When a baby doesn't have good intake, they are more likely to develop jaundice. And jaundice is so when the bilirubin levels are high in the blood, they sometimes need phototherapy, so the blue light. So when they need blue light, they will also need supplementation. So they will be given bottles, which can then kind of derail the whole experience. So then we get back to the colostrum harvesting. So having a little bit extra to give to the baby for situations, for like what you were saying when you were separated from your baby, to make sure they are fed well from the beginning, frequent feeding, and if they are not latching, then you can hand express and give that via syringe. So making sure that baby feeds every 2 hours, every 2.5 hours, and watching out for those sucks and swallows to make sure that baby is actually removing milk. That will prevent that whole, slippery slope of the baby developing jaundice. So the more intake, the more the baby can kind of flush out the meconium. Once the meconium is out, then the kind of the rate of jaundice usually goes down.
That's
So
really helpful. That's really helpful. Thank you. We've got lots of information about jaundice on our website, so signs to look out for, etc. But that also leads me on to the worry that some mums can have about whether their baby is getting enough milk. How can we reassure mums whether they know if baby's getting enough or not?
So nappies are a very good indicator. Wet and dirty. I don't tell mums to write down how long their baby has fed, which breast. That is not so important. What I want to know is, do they come away from the breast content? There is a difference between milk drunk and content and exhausted. So we can tell the difference, right? A baby that's exhausted and you put them down, they wake up 20 minutes later screaming from hunger. A baby that's milk drunk will likely settle. You also want to really listen out for those sucks and swallows. And you can also tell the ratio between sucks and swallows. So a baby that sucks once and then has 4, 5, 6, 7 quick suckles in between, and then another suck, that baby is likely not removing milk efficiently. When you see a baby do long sucks, so they do suck, swallow, that's what we call a 1-to-1 ratio. Or it could be suck, swallow, suck, swallow. That's okay too. That's a 2-to-1 ratio. Those babies are doing really well. You can really hear a swallow after every suck almost, right? That baby will likely be super content. And I always say offer both breasts. The majority of newborns will need to have a kind of a top up from the other breast. So the kind of the rule of thumb is we do first course and main course on breast number 1, and we do dessert on the breast number 2. And there is another myth going around. We were talking about myths where some of the midwives advise my patients to give only one breast so that the baby can get to the hind milk. That's a myth. That is not true for the vast majority of mums. So the hind milk, the full milk hind milk, you get kind of as the breast empties, the breast milk gets a little bit fatter in it. The consistency is a little bit more concentrated, more fat. And the initial bit when we first start breastfeeding, the letdown is usually a little bit higher in water content. So that's what they call full milk and hind milk. For the vast majority of women who don't have a complete oversupply, they will get babies who are fed on demand frequently and they're feeding efficiently. They will get to the hind milk. We don't need to think about at what point during your feed does your breast milk suddenly switch to hind milk. It's not relevant. So you don't really need to worry about that at all. Sorry. Really
It's
annoying.
fine. The dogs like to greet everybody that come in.
And they carry on as well. Okay.
Do you think is there anything else you want to add? Is there any other questions you want me to add? Do you think that's pretty much it?
Yeah, you tell me what you wanted to cover.
Well, everything I've written down, we've covered everything. Because I've got about the colostrum, your top tips, dispelling myths, tongue tie, pain, expressing, and how to get support. So,
Perfect.
yeah.
Maybe what you could also put in, do you write it up, or do you put like something on there, like a
We have like a brief synopsis.
yeah.
Because
What you
this
could also
goes.
link with is the LCGB, the Lactation Consultants of Great Britain. So if people are looking for a lactation consultant.
Right. Well, I'll ask. This will be my final question for you then, and then we'll wrap up.
Yeah.
Is that okay? Because this
Yeah,
is
yeah.
perfect timing. I'm thinking the timing wise, it fits well. Okay, so that's really helpful, Sharon. Thank you so much. So just thinking about any parents that are listening to this now, they might be pregnant, they might actually be breastfeeding, they might be having some struggles. Where can they go to for support? Where's the best place to look?
So obviously a lot of information online. Your page sounds like you have a lot of information for parents out there. There's a lot of good Instagram accounts. My one is breastfeedingdoctor.uk, shameless plug. But if you're looking for a tongue tie practitioner, we mentioned the ATP, the Association for Tongue Tie Practitioners. And if you want a general lactation support, the best place to go, so the International Board Certified Lactation Consultants, they are all listed on the LCGB website, Lactation Consultants of Great Britain. And again, you can search by postcode.
That's wonderful. Thank you. And our website has a maternity directory on it as well under resources. And again, we've got the NHS breastfeeding support services as well. So if you wanted some support in your local area, like drop-in clinics, etc., there's information on there as well. Well, thank you so much for joining us today, Sharon. This has been absolutely fabulous. It's been fascinating, and there's lots and lots of top tips there. If parents wanted to visit your clinic in London, how can they get in contact with you?
So that's just www.drsilbersteinclinic.co.uk, and I have a second website. It's breastfeedingdoctor.co.uk. So both of these, but you can also search by name Sharon Silberstein. It will come up as well.
Fabulous. Well, we love all your tips on Instagram as well, so we'll continue to share them. So thank you for sharing them all with us. It's really, really helpful. Well, thanks for your time today.
Such a pleasure. Have a lovely one.